हाँ आशमा आए हुए हो क्या?
Yes,
बस
sir.
ठीक है, ज्वाइन कर रहे हो क्या? अच्छा, मैं डॉक्टर साहब को लास्ट टाइम भी रिक्वेस्ट करी थी, हमारे वो चल रहे हैं इन्फेक्शन कंट्रोल पे।
So we are live now.
Okay, done. Mute everybody else, please. Okay.
आए हुए हो क्या?
Yes, sir.
R.P. Gupta, President, International College of Dentists, India, Sri Lanka, and Nepal Section 6, and Indian Dental Association, Chandigarh State Branch. Eminent speaker of the event, Dr. Raghunath Mutaya, fellows from ICD International Head Office, members of the Board of Regents of ICD Section 6, Executive Committee members of ID Chandigarh State Branch, dear ICD Masters and Fellows, and dear colleagues from all across the world. I welcome you all to the 4th session of the certificate program on infection control and occupational safety in dental practice, being conducted by fellow Dr. Raghunath Mutaya from US, who is an authority on infection disease control in dentistry. We have had so far 3 extremely fruitful sessions where Dr. Raghu has covered the various infections we encounter in the clinical practices and very systematically explained us the various protocols we need to follow to avoid these infections in our offices. The program is initiated by ICD International Head Office in collaboration with ICD Section 6 and ID Chandigarh Branch. I know you are looking forward to hear Dr. Raghu, and without much delay, I invite Dr. Mahesh Verma, Vice Chancellor, Sri Guru Gobind Singh, Indraprastha University, and Chairman CDE, ICD Section 6, to take the proceedings further. Over to you, Mahesh.
Thank you, Rajiv. Let me acknowledge the leadership of ICD Section 6, as well as ICD Head Office, all our valued board members, zonal regents, deputy zonal regents, our distinguished fellows, and all the participants. Welcome to Module 4 of 5-session certificate program, as just informed by Rajiv. And we will continue our session. Last time, if you remember, we talked a little bit about water systems, its contamination, how do we control that, and also a little bit about sterilization of instruments and monitoring it, and how do we preserve the sterility of these, pouched and packed instruments. So just to recap, how we built the topic, we started with rationale of infectious diseases, the roots of transmission of infection, then certain basic control measures and precaution we got to take, especially in certain conditions like HIV, hepatitis, TB, influenza, SARS, all those. And then we moved to germicides and sterilants. What is the right way of choosing them? The process of disinfection, hand washing, personal protective gear, equipment, devices, prophylactics. And the last session, we talked about water lines. I think that is something which is which really need to know, and how do we carry out disinfection, especially the biofilm and fungus which grows in them. And not only that, some other contaminants in those water lines, and some of the dangerous microbes we talked about, which are growing along with fungus, which can really bring about serious diseases from lung infections to endocarditis. And then how do we take care of these water lines and ensure they are clean, and how do we test it? We talked about certain cultures and other tests, in-office tests. We also talked about reprocessing, sterilization of the instruments, especially the different areas of reprocessing cycle, and the importance of ultrasonic cleaners. I think that was a good information last time. And then Raghu, before he closed, he talked about N class and S class and B class. I thought he was talking about Mercedes. I never knew he was talking about autoclave. Anyway, well, he very nicely ended the session with how do we monitor sterilization? And he said, we can use spores, we can use bovine dig test, and he gave us a new method of a digital indicators, which you can connect to your computer and can make out. So thank you, Raghu, for building the information so far, and we are really looking forward to hearing to you for the rest of the session today and the next Sunday. Over to you, Raghu.
Thank you, Mahesh. So, thank you so much. Talking about the S class, N class, and B class. I wish we were in a situation to afford those class of Mercedes. But something, with 4 of the B class sterilizers, you can probably buy a Mercedes. If you can own 4.
Not in India. Of course,
No, I know. I mean, in India, everything is anything imported is overpriced.
Yeah, 300% duty.
I know. Hello, Dr. Bali. Now he's back. Okay. So I got an email from Dr. Verma. It was forwarded to me. One of the attendees of last week had mentioned that steroxy, I wasn't sure whether they were going to use it as a surface disinfectant or for water lines. So,
there were 2 products, Raghu. One was steroxy, which is liquid chlorine dioxide, 0.70% concentration. Another one was Acrocept, which are effervescent tablets. So I think possibly.
I'm not sure about the Acrocept, but if you can tell me the chemical formulation of the chemical.
Dichloroisocyanurate.
Okay, that one is a good one.
Yeah.
Dichloroisocyanurate, but you have to remember now let's talk about the steroxy first.
Yeah.
So I have tested the similar formulations of steroxy. In the US, it's called Closys. Closys, they use it as a mouthwash. Well, it does a pretty good job in neutralizing the volatile sulfur compounds in the mouth, to reduce the bad breath. But they call it stabilized chlorine dioxide. Now, that is a kind of a funny misnomer. Chlorine dioxide is a gas, basically. Okay? So what you have to do is you have to take a chloride, and then when you expose it to an acid, that is when it releases the chlorine dioxide. So when they say stabilized chlorine dioxide, it must be a chlorate. Chlorates are not just the stabilized chlorine dioxide on a dental water lines is not going to be a good option. It does not do much, even at the lower concentration for an irrigant or a higher concentration for a dental water line cleaner. It doesn't do a great job on removal of biofilms. I know that because I've done it multiple times. I actually had a grant from them, from Closest, the company. But people make a lot of claims of so many different things, and I've seen people using it for dental water lines. But the problem is none of the people who use it test it and neutralize the water in testing. Test it on R2A agar or at least on a millipore paddle. So I would stay away from that. Now, if you want to actually make it active, then you can add an acid to it, like citric acid. If you add citric acid to the steroxy or Closys, then it will release chlorine dioxide gas. Okay. Now, so we have to be very careful about what we do. Now, diisocyanurate, that one basically is a formulation which is used to generate hypochlorous acid. Now, once it generates hypochlorous acid, at what ppm, and then what is the pH? The pH should be around 6. The ppm should be hopefully greater than 3000 for a surface disinfectant. For a water line cleaner, 3000 is good. You can even come down to 1000, but I would stay with the 3000 and expose it for about 10 minutes to remove the biofilms. So that is one. So what is the tablet, Mahesh, you're talking about, the self-dissolving tablet? Is that the isocyanurate?
These are effervescent tablets, and
Okay.
which contain sodium dichloroisocyanurate.
Okay,
Yeah.
how many parts per million of chlorine dioxide does it, hypochlorous?
I just saw the picture and I didn't go through the literature, but I don't know the ppm level.
Yeah, the ppm level for a surface disinfectant should be at least 3,000 parts per million. And when it is mixed, you have to look for how many days is their stability. Now, of the active formulation lasting. Some people have made claims of 1 week. Some people make a claim of 2 weeks. I have not seen greater than 2 weeks of claim. So once every 2 weeks, you have to mix it. Now, the quality of water, that is a very, very big issue, in the US, at least I'll tell you. So in the southwestern part of the United States, there are a lot of limestone deposits. So the water we get has got high TDS, total dissolved solids. So about a month ago, I went down to Galveston area, Alvin, Texas, and one of my friends, Dr. Chris Hoffpower, he practices in Alvin, Texas, and is a pretty big, busy practitioner. We tested the water, the tap water, what comes out. They have 1,000 TDS out there. 1,000 TDS is very, very hard water. Now, in Dallas, normally it is around 300 to 400. In my house, I get 500 because I'm in the outskirts and we get community water supply, maybe from a different source than Dallas. So our TDS is 500. So the greater the TDS, the lesser active your active ingredient will be. So it has to be mixed in distilled water at least, where the TDS is much, much lower. If it is distilled and filtered, you can bring it down to 0 or 10 TDS. But distilled water, commercially distilled water, you can mix it in. And that has got normally low total dissolved solids. So that is the thing. I mean, this is for any of the disinfectants. Now, you do have tabletop distillers in the US. We use that quite a bit. What they do is they distill the water at night or early in the morning, and then they use that water for dental water lines, for the ultrasonic, for your autoclaves and so on. So the goal is to have low TDS. And then, Mahesh, we have low TDS meters. I'll send you a couple of them. pH meter and TDS meter. Those things cost about $10 or $12. That's all out here. You can get it in Home Depot. When somebody's coming down there, I'll send it to you. It is a good idea to get to know what the TDS is. See, in Bangalore, there's a shortage of water supply. So we get water from bore wells, we get water from so many different sources. My mother-in-law's house has got a bore well, and then the TDS is high. So we either have to use reverse osmosis, even reverse osmosis is not a good thing. The best way to do is use large filters and replace those filters, for these things. So I hope that has answered my question.
Okay.
Answered your question.
No, but only thing is, Raghu, this is a big enigma here. Raghu, it's a big enigma to clean the water lines. Because the water which comes in a turbine is mostly, people use distilled water. So, but, these water lines, how do they clean? This is still, so you give them a cookbook recipe, because everybody is looking, because there are so many things available, and some of them are not available here. I know, incidentally, in the last week, a company came to me, and they are intending marketing these waterline tablets, and they were doing a survey whether it is a good product, and they know that it has a market in India because there is no competition. So they were
Correct,
actually,
correct.
probably they were surveying doctors, and they came and interviewed me, and they usually that's their system. So I think some products are on the way, but at the moment,
Right.
we have very high-end practitioners here. Dr. Sharad Kapoor,
Correct.
all
Yep.
Dr. Rajiv, Dr. Bali, Dr. Meera, they all, see, they. So what is the cookbook recipe for them, that what they should be doing?
So, you talked about the self-dissolving tablets with the isocyanurate, urate. Those, if you can find out what the concentration will be, that is it's a good start.
Good product.
If they,
It's a good product.
it's a good product. I mean, basically what it is it's a hypochlorous acid. That's basically what it is. The electrochemically generated ones, you can't get that high concentration, but this one is good. Now, cost is another thing. In the US, there are 2 tablets available, 2 formulations, and one tablet made by one company costs about $15. So $15 will generate one bottle of the disinfectant, but there's another company which has got much lower. It costs about $4 or $3 for almost the same formulation. And most of these in the US come from one source. It's based out of Ireland. The patent is based out of Ireland. The company owns it. So these guys actually subcontract it from them. But hypochlorous acid has been there for a long time. I mean, there was one company, which is the company that makes anesthetic carpules, Septodont.
Yeah, Septodont. They're French. It's a French company. It's
Correct.
a French.
They at one time had a bromine cyanurate derived disinfectant which lasted 2 weeks, and that's a good one. I mean, that was approved in the US as well at one time, but they disappeared. Now, if this hypochlorous acid can reach 3,000 parts per million, it is a good thing. It can be used for surface disinfection, very good one, and it can also be used for dental water. The first thing for dental water.
The story is that there are abundant chemicals available here in India. If we can prepare a solution of 3,000 ppm of hypochlorous acid, we can use it. Is that right?
Yes. And then we have to see what the stability is for 1 week or 2 weeks or 3 weeks or 4 weeks. So for that, you can actually measure. You can get a dip strip to measure the pH, and then there's also the chlorine content dip strip to measure the chlorine content. So basically, you got to ask them how long it will last, how long is it stable, and how expensive is it. See, the problem in India is I have seen chemicals which never cleared the market in the US, but they have been dumped in India quite a bit. Every time, you remember, Mahesh, I used to disappear when I used to come for the meetings. Where was I? I was actually talking to the companies, to see what they have on the devices. I always do that in every meeting. And what I found was things that actually some of these people or formulations had contacted me to test water lines, to see whether it's a good disinfectant. And when I look up the EPA list, it's not listed as a surface disinfectant. They never cleared it. So what happens is the ones which are not cleared in here or Europe, I'm kind of ambivalent about because I'm not very familiar with their process. But in the US, the EPA and the FDA process, I know, because all of these are medical devices, or medical devices adjunct. So if we can find out what the cost is a very big thing in the US also. How often will we have to clean, given concentration? How much is the cost per bottle? If you can mix 1 or 2 bottles and you can use it up within 2 weeks. That will be a great thing. That's what I advise people to do. Not have a bottle at every operatory, but have 2 bottles. Keep it in a common place. Yeah.
Yeah, the company which is planning to launch in India is called Sterilization.
Sterilization.
US-based company, Sterilization.
Sterilization. Hold on.
Yeah, Sterilization.
Sterilization, if that is the company, I'm not very confident about it.
They have
Yeah,
Citricell and Sterilization. Citricell and Sterilization.
Yeah. Yeah. Okay. For 3 years, they tested that the Sterilization product in our school. Okay. Now, as I told you, if you have low TDS water, they also sell a low TDS making machine where you connect a water source to it and then it will develop almost low TDS. Okay. That machine in the US, they were planning to sell it at quite an expensive cost, about $3,000 or something. And then you have a bottle insert, a tube, which goes into your intake tube, which is into your bottle, your self-contained water system. And that releases, what they call, they claim it is probably, silver dihydrogen citrate.
Yeah, it has silver. It has silver in it.
Correct.
Yeah, it has a silver, and it has 2 kinds of tablets. One is a shock tablet, another is a regular.
Correct, the larger one.
Yeah.
Yeah. Number one, I haven't been able to test it because whenever I had to test anything, I can't do it for free. It has to come as a grant to the university. And they were not willing to spend the money. Okay, but they went to another university probably and then got a lower price and got it done. But our school, in good faith, the clinics, they tested it for 3 years and they could never get good numbers, acceptable numbers. So they discontinued that and then they went for another one, which is Dentapure. Dentapure, I had tested it in between 1999 and 2001. I had also developed all the protocols and shared it with them to give it to the EPA and the FDA because Dentapure provides 5 parts per million of elemental iodine. Now, all these things which go into the bottle, you still have to shock it in between. So Dentapure, they said you don't need to shock it. But if you look at my publication, you do need to periodically shock it. If you have a low-grade antimicrobial in your lines, there will definitely be certain microbes which will be resistant, will become resistant to the low-grade antimicrobial, and they are called monocultures. Now you look at COVID, the variants, we call them. Some of those variants, they have evolved to avoid, microbes evolve all the time. So if you have like the variants in the bacteria, like viral variants in the bacteria, you have certain microbes that become resistant to the antimicrobial you're putting it into the lines. And if they are monocultures, they become blooms, huge amounts they become. And even if they're not pathogenic, at that concentration, it will definitely be a facultative pathogen. I don't like most of the waterline microbes. They're mostly gram-negative rods. Okay. Most of our issues in control are gram-negative rods. Next week when we have Prashant talk about antimicrobial stewardship and antimicrobial resistance, we don't have that many, antimicrobials in the form of antibiotics that can control most of these resistant microbes. We have only 3 or 4 left. Before we can make new antimicrobials, these microbes actually become more resistant. So I would stick with hypochlorous acid for now. and I worked with it. I mean, I worked with electrochemical ones. I worked with the tablet-based ones. They are fantastic. Now, the steroxy, that one, if you can ask the company, can we mix it? What concentration of an acid can we mix it to bring it up to 30 to 100 parts per million of chlorine dioxide? That you can use to flush, to do the shock treatment, and not for more than 5 minutes. Okay. There's one. Pardon?
I said we can go ahead with the formal your presentation.
Sure. Yeah. So what I'm saying is, you can use the steroxy only if you mix it with
Acid,
with an
acid.
acid. Correct. So
Citric acid.
Citric acid would be a good start. Yeah, because citric acid is safe. There is another company called Frontier Pharmaceuticals in New York. They had developed probably one of the best formulation. I think they use some lactic acid or something, if I'm not mistaken. But the formulation was a good one. I had tested that, and that is fantastic. You can, even at 30 parts per million, you can remove the biofilms, eradicate the biofilms. Now, the downside of chlorine dioxide is if you mix it and put it into your lines and forget to flush it out within 5 minutes, you might end up ruining your system if you keep doing that. So you have to be very careful. The chlorine dioxide at 30 to 100 parts per million has a pH of 3. 3 is pretty acidic. So you got to be very careful with that. It's good on plastics, it's good on naugahyde, but certain metals, the nickel-plated brass, all those things can be, on steel it's fine, but high carbon stuff, the nickel-plated brass, copper, and those things, it'll actually do a number on it. So you got to be very careful when you use chlorine dioxide. But there is one formulation which it's called Vista Tabs. Actually, Engelhardt, which became BASF, they contacted me. They wanted me to test their formulation. I did a very rudimentary test, and then they took that information and went off to the FDA and got it cleared. So, but when I told them you have to do corrosion tests, they didn't want to do it. Okay? But they claim it's non-corrosive. I don't agree with that statement because I have done corrosion tests. To do a corrosion test for one particular chemical, if you want to run it through a university, the direct cost will be about $30,000. And although BASF and Engelhardt, one of the largest companies in the world, it's almost like Dow Chemicals. They didn't want to spend $30,000 because they'd already got a clearance. And then now I see it's being marketed by U3D, but now I see that if they say that it's not corrosive, I'm sorry, it is corrosive. So, so you have to be very careful. Mahesh, I have a request for you.
Yes.
Since you're a head of a university, make me the Czar of infection control products for India. 1 year contract.
Wow, you're already a Czar.
No, I know. Once
You're wearing
we can
the
do
crown
it.
at the moment.
No. So, no, but what I'm saying is, you have to be very careful. I've seen chlorhexidine-based surface disinfectants. They're not good. They don't kill TB. I saw, a couple of weeks ago, somebody had sent information, and they said when they looked into their surface disinfectant, it had no TB kill claim. So if it doesn't kill TB, it is not an intermediate level disinfectant. So, well, Coca-Cola can kill TB, but it'll probably take 24 hours, but it has to kill TB within a reasonable time, 4 or 5 minutes, if you use the quantitative test. If you use the AOAC test, they can say it'll kill in 30 seconds to 1 minute. Some people do that. So that is one. So last week, Dr. Bali said let's go through a checklist. Now, is there any other question, Mahesh,
No,
for now?
no.
So now, talking about checklist, now we have to go back to 2008, 2009. Remember, we got the standards done through DCI. Then you had conducted the pathway to continuing education, at Maulana Azad. And we had 2 sessions of that. It was a pretty big, long thing where we had pretty much almost all the DCI, state DCI, Dental Council people there. I mean, so you had the legal heads out there. And Kohli was at that time, the DCI chair. And we came up with pretty solid, you asked me to give my experiences of what we're doing in the US. I did. Within the US, although people and the rules have been there for the past 60 years, people are acclimatized to it because they have the state dental boards that investigates every complaint, if it's a valid complaint. Then you have OSHA for employee safety. Then on top of that, you have the state health department, which can shut your clinic down. There are times when people have called me, my clinic was shut down by the county health department because I didn't have anti-retraction valves between my building and municipal water. So there are very strong restrictions, and then there is oversight. Now in India, our Indian philosophy of everybody's, "Arey yaar, it's okay, chalta hai." In Bangalore, they say, "Solpa adjust mani." Come on, yeah, we are very forgiving people for each other. When it comes to patient care, it is life and death. The first thing we have to think about is do no harm. Whatever we try to do no harm. And that's a pretty simple thing. It can come from, Hippocrates, it could have come from Sushruta, or it's a very pacifist.
Non-maleficence.
Correct, non-maleficent. No. Yes. So it could have come from Gautam Buddha too. Do no harm. It could have come from Gandhi. So the problem is, we have had many cases where people have taken shortcuts in the US, in Europe. I mean, people do that. It's just people try to, shadow the rules, or they sunset the rules in the clinic. And that's not a good thing. In India, till we get good oversight, it is very difficult. We started off that time saying, first 5 years, we will not be auditing you when you go renew your license. But after the 5 years, now what happens is things change, the heads of the organizations change. Then there'll be other competing views of different things which will have come up. And what is there in the India Gazette is forgotten. Now, there has to be a group, a body that will concentrate on dental safety, infection control, occupational safety. The same group hopefully should be the oversight for devices that claim, and use of devices like disinfectants all the way to sterilizers. I'm not talking of dental materials. Dental materials, it's fine. I mean, people get to know when the composite will fall off more often, and people, that thing will go lose the market. But I'm concerned about, if you're not doing the right thing in the clinic, the patient can die. There are other things, talking about as simple things. Whenever a patient comes in, you take the blood pressure, you take the pulse. Okay? You can ask questions on bisphosphonates. There are so many questions that are there which needs to be done for patient safety. When we're talking of infection control, it's a totally different thing. I mean, it falls under the same thing, same patient safety aspect and employee safety aspect. So I think, we have to have a group that will oversee, implementation and audits. If there is nobody doing the, overseeing the implementation or doing the audits and holding a person responsible, people will not change. So that is my take, Mahesh. And you all are You know, you're the cream, you're the premier group. No, I mean, you are, because, you know, you have traveled around the world. You've seen how practices are there in other institutions,
But, but Raghu, I must confess here that although, you can say that in India, the awareness for waterline disinfection is not so much, but I think that is the same status in US. It may be marginally better, marginally better.
No, I'm not comparing anybody out here, Mahesh.
Yeah, but
what I'm saying is, in the US, you see, there was one case, in California. It was a public health clinic, predominantly treating children. Okay, it was a public health clinic funded by HRSA. Close to 70 children had to be hospitalized because of TB site infections. There was another clinic on the East Coast which had the same problems. It is not Mycobacterium tuberculosis, but it is the family of Mycobacteria that cause site infections. Now, in the US, less than 10% of the people have good water, good microbial quality water going into the mouth. Now after I retired, I've started my own, consulting and training. I do training through Zoom, and then I do walkthrough of the offices. I help them clean up their systems, in place. Have good systems in place, clean up all the issues. Water lines, I've gone to multiple clinics, taken the sample and left the sample in the clinic so that they read it. Every clinic I've gone to, there's not one clinic, Mahesh, even in a dental school situation, in our dental school, to bring in control of 317 dental units, which are water systems. It is impossible. There are competing other things which people will do. So what, to most of these clinics, I've told them, look up everclean tablets by, pure tabs by everclean. It's less expensive. It produces 3,000 parts per million, and it'll cost about $1, for cleaning a chair. So you have to shock the chair at least 4 times the same day. And then once a week, you have to shock it for the next 4 or 5 weeks, and then take the quality measurement, like microbial quality, test it with a millipore thing. And once it shows that it is less than 500 colony forming units, then you can clean it once a month. Now, every 3 months, you have to test it. Every chair. Now, in India, if you have to do that, millipore, each sampler is about $7 to $8, depending on where you buy it. If it is cheaper in India, I don't think so, because one of the people I used to know was my cohort, was the scientific head of millipore for India. It also set up a testing center for Bangalore, not for the millipore HPCs thing, but for their products, And well, most of these companies do not reduce the cost when it comes to India. Indian dentists, they cannot, it's a non-comparison. Like in the US, after 10 years of practice, if you run your practice well, you are very wealthy. You reach the bracket. In India, it is hard. Probably 1 out of every 100 has got a very good practice. In the US, I would say about 30%. So, and the cost of dental treatment in India is also very low. So if these companies come and sell it at the cost where Indians cannot afford, then I would want the least common factor, the most common factor, which is people that cannot afford most of these devices that are made in the US. I can understand that because I practiced in a clinic, which was when I first started. I practiced in a clinic and I was taking home less than 1,500 rupees a month. At that time, my father's salary was 6,000. Okay. When I joined ICMR, it was 2,200, as a research officer. Of course. Now things have changed in India, I do understand. We cannot think about only the clinics that are running really well and have had a good history. But those are very few. We have to think about somebody who just started new practice. Can they afford it? Somebody who is practicing in a semi-rural or a rural area, can they afford it? Is a question. That is why I asked you if, we have so many educational institutions, if we can develop a chlorine dioxide or a hyperchlorous acid formulation in a dental lab and using an analytical chemist, and then make it into a product. We can get federal grants for that. You've had federal grants, the CSIR grants and so on. And it shouldn't take much time. And it'll be so inexpensive. Raw materials are inexpensive, Manish. Most of the world's raw materials are produced in India or China, for chemical purposes and at the medical grade. So we do have opportunities out there. If you can keep it at 20 rupees for shocking, they will use it. If you keep it at, pardon? Yeah, if you keep it at 100 rupees, then it will be expensive for them, they'll say, because it will cut into the, their earnings. So instead of shocking it once a week, they'll shock it once in 2 weeks and may not be effective. So you see, that is one thing. Then sterilizers, a sterilization of handpieces. Last time when I was lecturing, remember, in Delhi, there was a pediatric dentist who asked me a question. He said, sir, I see about 40 to 50 patients per day in my clinic. How can I sterilize my handpieces for these number of patients? I said, what is the common thing? He said, most people wipe it down with a disinfectant. High-speed handpieces. So I said, well, a high-speed handpiece sucks back the material from the patient's mouth. It'll have blood, it'll have saliva. What if it's a person with a viral disease like HIV, hepatitis B, hepatitis C? You have to sterilize it, a heat sterilization process. We cannot immersion sterilize a handpiece, but it has to be sterilized. He said, but I can't afford so many. I said, sir, you have to set an example. We are seeing 40 to 50 children per day. If you can see that many, are you doing it for free? He said, no, mine is a for-profit. I said, in that case, you can afford to buy more handpieces, and you can cycle those handpieces. He said, but it's so expensive. I said, well, life is expensive. Infection is expensive. Hospitalization is expensive. A lawsuit is expensive. So there are, there was one gentleman I met actually with you. He was from Bombay. He was a lawyer at that meeting, if I'm not mistaken. And I had a pretty long chat with him over coffee. He said, where he practices in Bombay, there have been a lot of lawsuits. So legal issues are coming up into the forefront. We treat people who are educated all the way to uneducated people. Now, the educated ones are the ones who will end up suing you. So I don't know where that's going to happen in India, but so that is another thing which drives. In the US, a lawsuit is more important than the standards. Suppose there's a lawsuit against one dentist, it gets onto the news, all the dentists will get scared and then they'll follow rules because they're afraid. Then the dental boards, they will actually block your license. They'll take away your license. The case in Oklahoma, the oral surgeon, I was the counsel, or actually the expert from the plaintiff's side. The minute they got to know what the guy did, Oklahoma State boards just cleared his license off the bat. I mean, they kicked it out of the ballpark. Okay. They can, on more lesser infringements, I've seen even the Texas state and the Oklahoma State boards, they have held back a person's license for a given amount of time. They're not allowed to practice. You know, it'll be like COVID times because you can't practice. If you can't practice, how can you pay your bills? So there has to be something which is legal, Mahesh. You know, so you have to look at it from that point. If there is nothing, if there is no legal consequence, then people will not change, Mahesh. You know, you know that, you know. You as a head of a dental school have seen more legal issues because they think a school has got bigger pockets, right? But at the same time, you are the educator. Even at that level, you've seen legal issues. Now think about somebody left on their own in their own clinic. They can do all kinds of things if they're not good people, you know. So that is another thing, you know, education, monitoring of their CE credits. That's another thing. Who's giving the CE in this field? Hardly anybody. You know, so those are the things, you know, when we required 5 hours of CE every 5 years, you know, that thing has not been implemented, Mahesh. I asked clinics in Bangalore, you know, and Coorg. So are you guys following, you know, the guidelines of the rules that were presented in the Gazette? I said, no, doc, it hasn't trickled down yet. So, you know, there has to be somebody, there has to be a body, even within DCI, there has to be somebody, a group that follows up on the infection control part, on the safety part. You know, that's a must, Mahesh. You know, and I'm sure there are DCI members out here.
No, you see, I think it needs a wider discussion. I think this is not the platform, but there are so
Correct.
many ramifications, so many areas. We
Exactly.
have the government has come out with a new act called Clinical Establishment Act, where
Correct.
every clinic will be supervised. They will be ensured that they have a type B autoclave. They can be inspected, but people, all of us are trying to thwart it with a nail. We don't
Right.
want it. They say
Right.
it will be an Inspector Raj, and you know, so there are many ramifications.
Correct.
So let us move ahead. At
So-
least you preach us what is right.
No, when they advertise for the head of that group, let me know. I will become the infection control czar for India. I mean, what I teach is the same thing which can be applied to medicine as well, you know, so that's the joke. But
But
where is the, oh, this
we
document.
put the water lines last time.
No,
Yeah,
I know, but I actually have.
You ended at digital indicators.
Dr. Mahesh,
No,
Dr. Mahesh,
yes,
Yes, sir.
I just wanted to say that many times up to now, many people are using handpieces with retraction valve, which has a suckback mechanism.
But
And
even
that
then,
has
they
been,
all also have to be disinfected, sir. They
Right.
also have to be
but,
sterilized.
but the handpieces has to be with non-retraction valve. That is the thing they have to bring it now. That is very important, which the people are using.
no,
Hello, Dr.
and-
Raghu. I am very Prakash.
hello, sir. Hello,
Hello, how are you?
sir? I'm good, I'm
Fine.
good. Now, you said that we have to bring back anti-retraction valves.
Mm.
Now, so, you know, between 2002 and 2007, I was the consultant for the Italian dental boards, the University of Bologna, and the Italian Trade Commission. We did a study on the failure of anti-retraction valves. So, and also Castellini, the company, you know, they were also involved through the Trade Commission, University of Bologna, and La Sapienza in Rome. You know, Giovanni Dolci was the head of the Italian dental boards. The main infection control pusher was Dr. Montebugnoli. And of course, Franco Castellini was the head of Castellini. And then the Italian Trade Commission. It was actually a fund from the Trade Commission to expand the things. We found that after 8 uses to 10 uses, those anti-retraction valves fail in 80% of the cases. There's a paper that they published as well. So I do not like the anti-retraction valves. That's number one. It actually pulls back, it holds back the water. In other words, it actually actively sucks back. When it does that, it actually sucks stuff from the patient's mouth. Now, there was a study that ADEC, Jeff Zavada from ADEC, is also the representative from the US for the ISO. But he was a research scientist for ADEC, research and development scientist for ADEC. You know, when you take your foot off the rheostat from your handpiece for running your handpiece, there's a suck back which happens. The eddies actually pull microbes along with your saliva back into the lines. And he's measured it almost up to 24 inches back into the lines. Okay. So in the US, they've gotten away from anti-retraction valves. Of course, it will drip on the patient, big deal. I'm okay with the water dripping on clothes. I'm not okay with sucking that patient's saliva back into your thing and then putting it into another person. Now, the hand pieces. Now let's talk a little bit of instruments. The instruments must be in pouches. That UV light disinfection and preservation thing, those cupboards they have, those are not good. They are not consistent. They are, in fact, not allowed, at least in the US, and I believe in that very strongly. If you can aseptically take any of those instruments and drop it into a broth, 90% of the time you will find that there is contamination. Whereas if you take one from a sterilization pouch and put it into the, what do you call it, a broth, you will not have that issue. It will not be any growth. So it has to be in a pouch. So we have to work from ground up. Instruments have to be put into a pouch and then sterilized so that the sterility is maintained for a thing. And then people will say, oh, how do you know? I mean, there's no news on infection caused by using ultraviolet light. I would counter that by saying there is no investigation by any authority. If they did investigate 100 clinics, I'm very sure that only about 80%, only about 10% of the clinics will pass. It's just like when people saying, where are the dead bodies? If we do surveillance actively, that's only then you'll find the dead bodies. Okay. I'm not saying that there has to be dead bodies, but I'm talking of sterility. A patient comes expecting to be treated, not pick up a disease. Okay. So it's our job to do that. The other thing, so we have to get rid of those UV chambers. They're not, nothing is, I mean, evidence-based wise, it is not work.
That's only meant for barbers. If
Yes.
they can keep their comb and there.
Correct. I mean, one second.
So this is the checklist you're talking about today.
Yeah, I mean, this is an older checklist, which, I've been using for the past, 15, 20 years. I'm very sure you have a copy of this as well. So, this is a self-assessment checklist, I call it. And this is for infection control and OSHA, not for HIPAA. This is prior to COVID. So there are no things on air evacuation systems and all those things. So here, allergic to latex gloves, non-latex gloves to be used, non-latex dams, rubber dams. Instead of rubber dams, you have to use non-latex dams. Close to 7 to 13% of the US population are are allergic to one form of latex or the other. Then do you have questions on the TB status in the patient's chart? Cough of more than 3 weeks, possibly tinged with blood, weight loss, malaise, feeling feverish, night sweats. Those are conditions which we should introduce into the medical record of the patient before we treat them. Then health history. Then also every patient when they come in and for every visit, take the blood pressure, take the pulse. Maybe in a rested sitting position, maybe you can be the people who diagnose that they may have hypertension. That's number one. The next thing is, if you have very high blood pressure because you're stressed out, people with high blood pressure do not get what you call a stroke every day. The stroke happens once, and then there's debilitation. When does that stroke happen? When the blood pressure is high and shooting. Is it always doing that? No. But in a dental unit, in a dental chair, when the person sits, normally the blood pressure goes up. Okay? You want to make sure that you're in the safe zone when you're doing any of your dental procedures. A patient can go through a stroke, get a stroke or a TIA, when they're in a dental chair. So that's although it's not infection control. Then antimicrobial prophylaxis for conditions as indicated for patients with joint replacement. And, everybody thinks that people with joint replacement, you don't need to go ahead and provide antibiotics. No, you have to refer back to what the kind of outcomes there were from the joint replacement. Was there a later infectious thing which was later cured? They fall under a higher level of scrutiny. So you have to fall back on the orthopedics person, to see whether you need to put them on that. Then cardiac issues. Although for normal patients who have had a history of cardiac issues, like endocarditis, we don't need to, but there is still a certain segment of population that have an indication for antimicrobial prophylaxis. Yes, there are. You have to fall back on that as well. But by and large, not necessary. Pre-procedural mouth use, a change of barriers on equipment between patients, disinfection of eye surfaces if visibly contaminated, if you're using barriers, use of intermediate level hospital disinfectant with EPA registration for surfaces, unit dosing of sterile instruments. You dispense the X amount of instruments and materials you need for that particular procedure. After the procedure, if any of that thing, the dispensed one is still there, you got to dump it. Okay, you cannot put it back into your supplies again. Then unit dosing of materials and single-use disposable items before starting procedure. In the US, I have seen cases where people are supposed to discard after one use because they're sterile single-use disposable items or single-use disposable items, but they stick it into glutaraldehyde to reuse it. No, don't do that. It's not cleared for that. Hand washing with the germicidal soap before wearing exam or surgical gloves before starting the procedure. Patient's bib and patient's eyewear. Dispensing red biohazard bags for saturated soft waste. Presence of sharps container accessible to the in patient care areas to dispose sharps. Use of rubber dam in combination with high volume evacuation to control bioaerosols. Okay. Use of HVE during oral prophylaxis procedures. Use of PPE based on anticipation of exposure to splash or spatter. That's when you go for full PPE. You dispense an over glove, just in case you're doing a procedure, you need to go back to the drawer, pick up something else. You have to wear the food handler's glove over your dirty gloves, or get rid of your dirty gloves, then go get it, wear a new pair of gloves, get your supplies, and then start the procedure. Those things are there. Use of barrier recording devices. Everybody's doing, digital stuff now. So your keyboards need to be barriered, your controls need to be barriered. Okay. Then avoid contamination of patient records with dirty gloves. If you're still using a paper record, there should be four-handed technique. Somebody else should be doing it. Doing the entry. Use of unsecure and hard-bottom container for using of secure and hard-bottom container for transporting contaminated instruments. Prohibiting employees from wearing PPE in patient waiting areas. Examine glove for tears, punctures, or hands right after the treatment procedure. Washing hands with germicidal soap and water after removal of gloves. Use of emollients on hand at the end of the clinic session. Okay. Use of nitrile or heavy-duty gloves during instrument reprocessing. Dirty instrument reprocessing in the receiving area for contamination. So there has to be a dirty to clean, flow. Separation of instruments and hand pieces before placing in instruments or holding solution. You have to follow manufacturer's recommendation for protocol for reprocessing hand pieces. NSK has got one, Cavo has got one, WNH has got one, ADEC uses WNH. They use the Sistina. So each different types of hand pieces, they have different cleaning mechanisms. You have to follow the manufacturer's recommendation. Use of ultrasonic devices for cleaning instruments. Examination of sonicated and rinsed instruments for unremoved bioburden. Okay. Use of a long-handled brush to clean out that particular instrument. Use of chemical process indicators during sterilization to see if cycle was complete. But I've told you before, right? All, including the biologic indicators, even they fail before half the sterilization cycle. Steps to ensure that sterile bags or pouches are dry before removal from the sterilizer. Okay? Storing instruments in clean zones, separate from the dirty zone or humid zone. Weekly sterilization monitoring. That is the rule of every state in the United States that has to be followed. But, we have to follow some rules for India too. Then measuring chemical efficacy if FDA cleared immersion sterilants are used. So you have to use, the dipstick or the dip strip to check if you're using any glutaraldehydes to see how efficacious it is, at least once a week. Measure for monthly testing of ultrasonic machines efficacy. Servicing of reprocessing equipment based on manufacturer's recommendation. Chair-side disinfection and rinsing of impressions before transportation to the laboratory. Storage of clinical supplies in clean areas. Disinfection of other portable patient care devices immediately after use, such as curing lights, the ultrasonic machine, the scalers, your X-ray units and all those things. Use of dental unit water system contamination control agents. Use of sterile water and sterile devices for surgical procedures during irrigant or for irrigation. When you do endosseous surgery such as implants or third molar extractions or getting a root out, you have to use sterile water. Okay? If you can't use, a thing like aseptico or some of those devices with a striker or other electric handpieces, then you can use, a slow speed handpiece, a straight handpiece, and you can use large monojet syringe to drop the water and keep cutting the tooth, to section the teeth and stuff like that or bone. For implants, of course, you must use sterile water. Radiological safety and related issues. Periodic review and update with respect to existing and new clinical procedures and devices. Some of the occupational safety stuff. In the US, we have bloodborne pathogens, hazard communication of globally harmonized systems, building and equipment safety. But what I want to touch base on is one second. Post-exposure evaluation and follow-up. Suppose you get splashed on or stuck. You know, it is a good idea to immediately, within 2 hours, you have to start treatment in case you're stuck.
Dr. Raghu, can you talk
yes,
about fumigation?
So fumigation, yeah, fumigation with a very strong agent for at least an hour is a good idea. But in dentistry for COVID, you know, people have said that 50 or 20 parts per million of hyperchlorous acid is good. And then you have to wait for 10 minutes and come out. No, there is no evidence-based stuff on that. I would say, you know, they follow a very different standard for the operating rooms. And that is where the data on fumigation comes. If we have to do that for dentistry, then we can treat 3 or 4 patients a day only. So fumigation, not a great idea. I would keep the windows open. You know, my first lecture to a group when COVID started, somebody asked me, if we have to treat patients, what do we do? I said, if you have a front yard in the clinic, put out a tent and treat a patient, you're much safer because you're exposed to natural air. Whereas in your clinic, if you do that, you have to have a huge amount of air evacuation. So fumigation is okay, but it's evidence-based, I don't know. For an operation room stuff, they do fumigate, but they do it once a day, max. But their evacuation system is great, their HEPA filtration system is great. So they have already addressed what happens for COVID way before COVID ever happened. But in a dental clinic, it is impossible. So they say, well, you can get a fogger, and then you can add hyperchlorous acid, about 20 to 50 parts per million of hyperchlorous acid, and fumigate. Sure, do it, but I have not seen any benefit of that. I would still prefer you using an air evacuation device which runs constantly with a HEPA filter, and that is a better.
Sir, how about the UV light?
So UV light, you cannot be there in the clinic. UV light has got 262 nanometers. It is also based on whether, if you have a UV light wand, you have to hold it for more than 20 to 30 minutes. Okay, I'm not talking of COVID. Anything which comes in to be used in dentistry. Can it kill TB? I would go with that. COVID is just the tip of the iceberg. We are very lucky we haven't seen huge number of mad cow disease cases in India. BSE cases. That would be a scary one, where they're not microorganisms, they're not viruses, but they're prions. How do you denature that? So UV lights, when they say, well, UV lights work in walkways, but at night when nobody's there, they blast the whole room with for a very long procedure. And it should be efficacious to reach the surface. If something is blocking the surface or the surface is too far away, it's not efficacious. So I would stay away from that. Okay? But if you already have it, maybe you can play with it and see what it does. But I've tested them, and when COVID happened, a lot of people asked me, can we use UV light? I said, yeah, you can use UV light, but the issue came up was, can we use it for decontaminating our N95 masks or respirators? I said, no, don't do that, because UV light, N95 respirators are made with a plastic kind of a material, actually, fine fiber. If you expose the very low wavelength, like UV light, it will cause shrinkage and porosities will happen. With 380 to 530 nanometer, the curing light, the white light and the blue light we use for curing composites, they cause shrinkage of composites, right? Yeah. You're talking of 262 nanometers, which is much lesser than 380. So the shorter the wavelength, the higher the capacity is to cause shrinkage. So I told them that. And then, Amy had a morning session for decontaminating masks. And they didn't even address the use of UV lights because they thought it was a non-starter. So post-exposure protocols, I would say. I mean, is there any other question on, on that? What I want to think about is a post-exposure protocol. When a person gets stuck or gets splashed on by patient material, like just got patient material like blood and saliva. Mahesh, and anybody in the group as well, can you please let me know what people do in India when they're exposed? Not in dental institutions. Dental institutions normally will have a medical officer, and those which are hospital-based will have a medical officer. But I'm talking of private practices. What do they do?
What you splash in the eyes or splash on the body part?
No, splash on the eyes, mucosa. Like on the eyes, nose, mouth.
Yeah, I think that mostly they usually, it's a common reflex. They try to wash the part.
Correct.
Wash it repeatedly, and maybe it depends on what kind of splash is it, what kind of chemical has been splashed.
No, not chemical. I'm talking of post-exposure from body fluids, but blood and body fluids, like while treating a patient or while handling instruments during sterilization process.
I think that's it. I don't think beyond that. And in fact, I think nothing beyond that. I feel that, they don't do.
How about dental institutions, Mahesh? Do you normally refer them to a medical officer to follow up?
Like, if they have institution is NABH accredited, they have a hazmat team. Hazmat team, and they cast for hazmat team. They come and help them, and they tell them what to do. And I don't know. I don't think it's.
So Mahesh, what we do out here, very simple. Every clinic has to do this, They will, of course, wash. If it falls on the eyes, they'll wash for about 10 to 15 minutes with the eye wash station. Eye wash station is a mandatory thing in every clinic.
In fact, most clinics do not have an eye wash station.
Correct. They use the bottle.
It has to be standalone, isolated, different,
Correct. Yeah.
They mostly use the shanks of their private toilets, or so.
Correct, but by using the hands and but anyway, they do that if it's a splash. But if it's a needle stick, chair side, they ask the patient if they want to come to a medical office where they do the post-exposure protocols, where they'll do a screening test by taking your saliva, which will give you on HIV. Within half hour to 20 minutes, it will give you the results, whether you're HIV seropositive or not. But if it happens in the instrument reprocessing area, Sharp's injury, they themselves will have to go to a medical doctor. I mean, of course, the clinic will pay for that. And then they will get on for a testing for hepatitis B, hepatitis C, HIV. And then, depending on that as well, they may put the patient on, the person on an immunoglobulin shot. They will give them a tetanus shot, they will give them a booster hepatitis B shot, and then they will decide whether to put them on Truvada or the antiretroviral medications. So that is the protocol, and then the reports are all, and then they do a follow-up for 6 months. And then they send the reports back to the individual as well as to the doctor's office. And they have to maintain the records for at least a period of 30 years, all employee health records. So, so there is a protocol every clinic must follow, and they should be trained in it. So, you know, some time ago in one of the meetings, not in 2018, I think it was somewhere 2015 or so, Mahesh, there was one dentist from New Delhi area who actually worked with the NABH. He came and asked me for all my information. I gave him all the slides, all my OSHA training material, everything. Pardon? So I don't know whatever happened with that.
No,
with
because probably, you know, because also, you know, there is a high attrition also in these organizations. So people leave and go and.
Correct. Correct. No, see, Mahesh, there has to be, I'll tell you one thing for sure. I mean, everybody else can listen. And I know that, you know, Rajiv will agree with me. Whenever there is a dental school dean who's there for many, many, many years in the school, most of the time, the school develops into a better institution. Number one, why? Because the person is very efficient, or the person is very aggressive in building the institution.
It can
take for example, take for example Maulana Azad.
But
okay,
it
Mahesh.
I
know it can be the other way too.
When you're there for too long, then you become complacent.
Mahesh, yeah, but the key was any good institution that has developed. It is not any stagnant institution. You know, in the you know, mid-80s, how big was Maulana Azad?
Raghu, I feel that it is not with a person or for how long is there. It's only, you know, the attitude to change and
exactly, Mahesh. But I was answering. I was answering the attrition rate.
Yeah.
You know, there has to be. That's why I say whenever it comes to things like infection control or OSHA and following up on that, it has to be a group of people with the same mindset.
Yeah.
Or it could be a society, it could be an organization which will have, you know, people will be there for 4 or 5 years, and then they will move on. The vice president will take over, but the vice president should have the same attitude. After the vice president becomes the president, the treasurer moves up to being vice president. So it has to be a cycling thing, but you have to choose the right person to run it. You know, or it could be a person like called Chiranjeevi who will be there forever, ruling it with a good heart. So,
Dr. Raghu, All
Yes,
India
sir.
Institute of Medical Sciences has the infection control department, and they regularly conduct the swab test and they take out whether how much is the infection. They are regularly doing in each department, operation theaters, national department, everywhere they are doing. There is a very regulated department and they have issued guidelines.
yes, I have their guidelines for dentistry. I was actually there. Now, I can understand in an operating room where you have to maintain sterility. In any other place, if they go ahead and do a swab test, it's useless. I mean, we addressed this in the mid-90s, early 90s. Many countries, like Saudi Arabia and all those places, they do that. You talk to anybody in the CDC, they'll laugh at it because microbes are ubiquitous, in a dental clinic, in a kitchen. After wiping down a surface with a good surface disinfectant, you are assured of a kill. Taking random samples of surfaces is useless. And what they are doing, other than in the OR, is useless. I mean, they may be All India Institute of Medical Sciences, AIMS,
Dr.
I'm
Raghu,
talking of, yes, sir. Yes, sir.
can I say, once
Yes.
when you come to India or Delhi, you must
Yes.
visit the All India Institute of Medical Sciences Dental
Yes, sir.
Center. That has
No, no.
come up separately, and that has
Correct.
been labeled by the government National Center of Excellence in Dentistry.
Yes, sir. I mean, I actually visited it when Dr. Karbanda was the head.
Yeah.
That was about, that was about 5 years ago, actually. I visited there.
Did you go to dental center?
Yes, I actually lectured to the graduate students out there on infection control. They had a whole afternoon session for me. That is also where I tested the sterilizers, and 3 out of 5 failed. Actually, using the digital indicator. And when I asked the people handling the sterilizer, they didn't know what cycles they were running it at. They just said, we press this button and we wait. And then they showed me that green label that sterilizer had been inspected very recently. So, the problem is, when I asked some of the faculty members, they didn't know what the cycles were either. So if the operator of the sterilizer and the faculty are not knowledgeable, I mean, it should be at the tip of your fingers. The pressure, the temperature, and the time for a cycle, whichever cycle you're using. The device has to give you a feedback after the cycle that the cycle was a success. Okay? Either in the form of a printout, or you have to use an indicator for every cycle, like a digital indicator. Now, they kind of were queasy and they said, probably your indicator is not working properly. So I just kept quiet. I didn't answer the question, but I told them, according to my indicator, and mine has got 99% accuracy. I wouldn't say 100%. Yes, sir. Yes, sir.
There is a question by one of the participants that whether the sterilization protocol should be different for different countries or it should be universal.
So the microbes are the same, we test across the globe. COVID in America, COVID in India, no difference.
No,
So
yeah, that's right.
The standard has to be the same. The knowledge has to be the same. The device has to be the same. That is why, Mahesh, I'm saying, when the government says, oh, you have to use a B class, show me in any of the developed countries where using an N-class sterilizer caused transmission of HIV and AIDS, hepatitis B, hepatitis C. 0. Check the literature, it's not there. Now, we were using boilers and boiling water, and those boilers were never cleaned. Mr. Walter Bond and Marty Favero, they identified a microbe that is heat resistant. It is called B. cereus. Cereus, cereus. So we used to call it be serious, like about sterilizing your instrument and not using a boiler. When I started practicing, we were using boilers. We never had autoclaves except in a hospital situation where they autoclaved even the rubber gloves for reusable gloves for third molar extractions. That's the only time I used gloves. Till I came, to the US in '88. In the villages, I didn't use gloves. I washed my hands or wiped my hands with a baby wipe. I mean, I had asked some of my friends to send me a stack of baby wipes because I was the only dentist in the group examining 30,000 people at their doorsteps. I used the ice cream stick as a tongue depressor. But if I had to examine a lesion, there were no gloves. Kidwai Cancer Institute didn't provide gloves. WHO didn't say anything about using gloves then. Only after I came to the US in '88, I started seeing glove use. So, things have changed. I mean, it has to be the same standard because microbes they do not discriminate whether you're Indian, colored, Japanese, Chinese, or anybody. It finds a host called human and infects the person, be it in America or Antarctica. Same thing. So standards have to be pragmatic and the same. That's why I say, if you don't have a B-class sterilizer, you can't afford a B-class sterilizer, use an N-class. Go ahead and change those rules. Ask the people who wrote those rules, how did these rules come into being? What testing have you done? What data did you follow? When I go and put my neck out training clinics, my company can get sued as well. So what I do is I actually speak the truth. I speak the standards. I speak, systematic reviews on science. That's where my information comes. When people were talking about not using a cell phone in the clinic, I said that is ridiculous. You're not going to handle your cell phone and walk in and start putting your hands into a patient's mouth. You're going to wash your hands and then wear your gloves and put your gloved hand into a patient's mouth. So where is a cross-infection happening out there? I challenge things like that. I challenge organizations like OSAP. I challenge what the CDC says sometimes. Last time I attended a lecture from the head of CDC for infection control on ambulatory care. And I thought that that lecture was a very disjointed one. People didn't know what they were talking. So it is not the standard. You have to question the source. You have to question the validity, the truth, That's why I say, even in the US, I tell people, if you can afford a Mercedes, for your wife or a spouse who's not a dentist, then use a Class B. In some countries, it's mandated like Europe. And do you know who ends up gaining? It's not you, it's not the patient. The companies that make the B-class sterilizers, ask them to show. See, what happens is they create so much of hangama that at the end of the day, and a lot of show and tell and pizzazz, at the end of the day, they convince authorities. That's one way of convincing authorities. There are many other ways too, but I won't go into those things because that's an ethical issue. But as far as science is concerned, it is a non sequitur. So, yep. Any other questions?
So one very important question. This question about the Class B autoclaves has come up now into our knowledge. I think this Class B autoclaves have been there in the market for quite some time, and people have been promoting it left, right, and center.
Correct.
Now, once this thought clearing process has come from your end, sir, it makes us feel that we really have wasted our money.
Yes.
When this promotion
as far as evidence is concerned, not only what I'm saying, initially SciCan, they were the first guys who tried to push the sterilizers into India. They were selling the Statim for ophthalmology care. They came up with G4 and G7. And then what happened in Europe and in some other parts of the world, they made it a mandate to only use B-class sterilizers or Class B sterilizers. Companies, ask every single company, show me the money. The money is, show me cases, show me systematic reviews where using an N-class sterilizer. We use an N-class sterilizer for what? From the 50s, we've been using them, right?
Yes.
In medicine and dentistry later. Guess what? Have you found any dead bodies since then? No. The minute an instrument is sterilized and you use that instrument on another patient, you will not have the previous patient's microbes viable. So that is what I'm saying. But companies come and dump stuff. I have done research with over 35 companies.
Sir, the company is going to get after you because you're killing their market also.
Yeah, I don't care. If they want to come and sue me, let them sue me. They have deeper pockets than me. I have bigger lawyers than them. So, you know what the equation is? I'll make money. I'll become a millionaire. So don't worry about that. I take, for example, there was this big company, large company, probably one of the biggest dental materials company in the world, and it's based out of the US. Okay, 4 states were suing them because their ultrasonic machine, 4 states, oral surgeons and periodontists were suing them. Why? Because one of the device was malfunctioning, one of the scalers. Well, the top 100 law firms in the world took up for dentists, and it became a class action lawsuit in a federal court. I was the one, the expert for the dentists, the oral surgeons and the periodontist side. Everybody else who were on the other side for the company, although I have consulted with this company multiple times, I met the head of the company. I made a lot of money from that company on consulting. Yes, but when it comes to the truth, you have to go to where the truth is. I'm not a lawyer, I'm a dentist. I'm an educated person in infection control. When they come to me as asking me to be an expert, what can I say? I will go on the evidence basis. I've been deposed for 7 hours straight for multiple days. Bottom line is you can only talk the truth, the known truth. 10 years later, I might be wrong because they might have found something better. But today's truth is today's truth. Till today, N-class sterilizers have not killed people. In India, people can afford N-class sterilizers. Class B sterilizers are 2 to 3 times more expensive. Class B sterilizers have more parts that need to be replaced, more movable parts like the fins, the fans of the vacuum system. Okay. To be frank with you, when you go to a field, you can get a 24-quart pressure cooker with a pressure gauge. And if you treat patients, autoclaving pressure cooking your instruments for 30 minutes at 15 psi. That is exactly what a slow cycle in an autoclave is. Where do autoclaves come from? They come from the canning industry. What did the canning industry use? They use pressure cookers. You see? Medicine got its autoclave from a canning industry, food canning industry. Yes,
Raghu,
yes, sir.
you just mentioned one company, Canadian company, SciCam. They had Statin, which had the cassette autoclave and whose cycle was just about, I think, 5-6 minutes only.
7 minutes.
7 minutes.
Yeah.
I had lots of them in my dental school.
Correct.
They all malfunctioned, and then I never could get them repaired.
Exactly.
But the 7 minutes, you think what type of autoclave were they? They were N type or B type? What were they?
No, they were actually the N type. But I'll tell you, Statin, this was probably over 10 years ago, right, Mahesh?
More than that.
Right.
Yeah. So
now the companies.
Yeah, they have today, to be frank with you, they make better sterilizers than they made about 15, 20 years ago. In the US, their sterilizers, like the G4 and G7, they're pretty solid. They tend not to break down as they used to break down in the Statin. So, yeah, they used to market it for ophthalmology use. The cycle, it is called a flash cycle.
Yeah, flash cycle. They have a flash cycle. That's right.
Right. The flash cycle is not permitted for regular use in the US. Why? In a flash cycle, the instruments go in naked.
Yeah, naked.
Did any of the Statin guys who came and sold you guys Statin tell you what the standards were in the US and they were not allowed to use that cycle? No, they don't. You know why? Because they lose the market. The flash cycle is only used in a hospital situation. Let's say, for example, there is a particular implant, a hip implant they have to place. And when they're doing the surgery, they opened up the hip and they're about to place the implant slips and falls down on the ground. You see, they can stabilize the patient, they can wash the implant, they can sterilize the implant using a flash cycle naked and immediately use it into the patient. But they have to wait for the cool down, of course. You can't, otherwise you'll have, you know, necrotic bone and the implant will get rejected. But what I'm saying is, it is only meant for a particular use like that. In dentistry, no. In dentistry, you have to use the full cycle. Now, Midmark came up with one thing similar to statin. Okay. Both these things can only hold X amount of instruments. And what I keep saying is get one with a large chamber, you know, like the M11, you know, the Midmark 11 or the G7 or a Tuttenauer old style machine, you know, large chamber. The reason is you can put more instruments in a large chamber, back, you know, in pouches. But the pouches have to be separate. They shouldn't be touching each other. You know, you need space between the pouches, and the pouches should come out dry.
Yeah, Raghu.
Yes, sir.
The last question, and then you can probably wind up because we already 1.5.
Oh my God, it's past 9 o'clock. Oh my.
So
Sorry.
last question is, what about chemiclave? There are a lot of these
Yes.
use chemicals with autoclaves. So what about chemiclaves?
Chemiclaves are great. I like them. They are very compatible with high carbon steel items. You know, more so in the surgery, in field of surgery, like where they use high carbon steel tips, they use high carbon steel blades, and so on, reusable items. Chemiclave uses vaposterile. It is a combination of certain chemicals, volatile chemicals actually, and it will have about 15% water. Now, the bat has got a cycle at 25 psi for 30 minutes. That's a great cycle. Very compatible. Now, the only downside is you have to have good aeration where the device is used. It has to have good scavenging systems to scavenge the volatile compounds that come out because of the vaposterile. If it's a new chemiclave, make sure that you know, I mean, they are good at scavenging the chemicals when they get into the air, and better scavenging systems. So make sure that the scavengers are replaced according to manufacturer's recommendation. They're good. So if there's any other questions, you know, you can always email me. Next week will be Dr. Konatham. He's an oral surgeon, and he's a faculty at the university in Missouri. So he will be talking about antimicrobial stewardship, and then, you know, it'll be about a 40-minute talk. And then after that, we'll have a final wrap up of any questions and answers. And where can we go from here would be the next thing. You know, for India, Mahesh, so Mahesh and others, I mean, other big people, I mean, you guys, you have to decide. And at any given time, let me know how I can help.
So Raghu, before we wind up, let
Yes,
me
sir.
just repeat some of the nuggets which we learned today. One is that you said that you need periodical shock, the lines, especially when using low-grade antimicrobials. So that is
Yes,
one.
sir.
And then you said using chlorine dioxide is a downside is that if you leave it for long with high pH, it may ruin your system. So that's
Correct.
another nugget. Then you said if surface disinfectant do not have a TB kill claim, it is useless.
Correct.
That's another nugget. Then we said we are, you know, that is on a philosophic side that we are forgiving people. So, but when it comes to life, I think we got to be harsh. You know, we
Yes.
cannot be Buddha and Mahatma Gandhi, isn't it?
No, No.
And then you said that for anyone in a dental practice, if you are not following the waterline disinfection, to begin with, you have to shock the chair waterline 4 times in a day, then once a week, and then maintain it by shocking once a month, and then testing every 3 months once. This is your formula.
Correct.
Okay, another thing you said that when we are using N95 respirator and using UV light, it can cause shrinkage of N95 and can bring about porosity. So the
Correct.
N95 and UV chambers do not go together. They don't go hand to hand.
No.
There's another thing that each one of us, we must follow a clear protocol for every post-exposure and a splash case, which we don't have. Every clinic should have eye washing stations separate and should have a clear protocols. And another thing very important is that protocol should be same all over, whether Antarctica or America. It has to be same. Then you said N-class sterilizers have been around and have not killed people. So it can be a standard in India. That's another nugget. And then you said flash cycles, autoclaves are only used in hospital setting because they use naked instruments and we cannot maintain their sterility. So they can only use for emergent use and that's it. And in dentistry, we need a full cycle and we need pouched instruments. So we cannot use them for a long. And finally, I think you said that chemiclaves are very good because they have a blend of chemical vapors and water. They follow a very simple cycle of 25 psi for 30 minutes. The downside is that you need a good aeration. You need a good scavenging system to vent out the chemical vapors. So we need to change the scavengers, as per manufacturer's instructions. So I think we've had, although we digressed and deviated, but I think at the end of it, we gathered a lot of information. And thank you, Raghu, for sharing it with us. And we look forward to your next and the last session, which is very important, antimicrobial resistance and antimicrobial stewardship, and antibiotic stewardship, ABS, MER, AMR, and also for any final answer to any questions, and then what next now? That may be as you said. So thank you very much.
I have one quick question which I wanted to answer. Dr. Raghu, do you think the infection control protocol should be tailored according to requirements of the country? Yes and no. On the protocols, it has to be science-based on the microbial control. That is one thing. Now, country-wise, if I have to think about Kenya, if I have to think about sub-Saharan African countries or Central African countries or Democratic Republic of Congo, where money is an issue, I tell them at least boil for 20 minutes, do your best. But in India, I don't think they need to boil instruments. I think we can follow a separate set of rules, but it has to be science-based. For example, I told you we have to autoclave. You don't need to follow American rules of testing the autoclave every week. I would say, if you can actually examine the output from a sterilizer if it has a printer, or on its screen, which it says cycle successful, only then release the instruments. So there are many different ways of doing it, but instruments have to be sterilized. Simple. I mean, in India, boiling water is not an issue. Boil water to drink it, but for sterilization, you can't boil instruments. So I'm just saying that if it is country-based, it doesn't make a difference.
And
thank you, sir.
For today's attendance code, I think it's already on a display. For code is IDA, Indian Dental Association. Thank you. So
thank you.
Anyone else has to say anything? Otherwise, we can. So there is no dry cycle in B class autoclave. How to do the dry cycle? Somebody has asked that. That's
Yeah,
all
that-
built-in. That's a built-in.
It's a built-in thing. I mean, it actually has got a,
It's a
class
pre-vac
B,
and post-vac, pre-vac and post-vac. Yeah, that's it.
post-vac has got the drying cycle. Yeah, built into it.
So thank you, Raghu. We had a wonderful time, and
Thank
we
you.
look forward to your next session. Okay.
Thank you. Bye.
Thank you. Bye-bye.
Bye.